Shall we go?
Yes, sir. You can start.
Sure. Thank you. Good evening, ladies and gentlemen. Welcome to Secrets of Neurology, Clinical Pearls coupled with recent therapeutic advances. Today is 29th of January 2021, and this is episode 7th. As known to you, it is completely dedicated to all the students in the field of neurology, and this is held on the last Friday of every month, and today is that day. The Secrets of Neurology is brainchild of our course directors, Professor Dr. Sudhir Shah and Dr. Lakshmi Narasimhan sir. We are extremely grateful to you and a very, very warm welcome to both of you, sir. We would also like to welcome HODs and faculty members from Department of Neuromedicine, IPG MER Kolkata, and we wish you best of luck for an excellent case presentations and discussions going forward. And a warm welcome to all the students, DMTNB students across the country. We normally close this whole discussion in a period of 1.5 hours. It's my honor and privilege to briefly introduce our program directors who needs no introduction. Because of his Dr. Sudhir Bhaisha, Professor and Head of the Department, NHL MMC and SBPI MSR Ahmedabad, and he is also Director of Neuroscience at Sterling Hospital, Ahmedabad. Because of his contribution to society, contribution to the field of neurology, and overall service, he has been conferred the most prestigious Padam Shri Award in 2016. Sir is also recipient of Dr. B.C. Roy Award and recipient of UNO Award. Many laurels to his credit, author of a lot of books which is still being read, and Dr. Sudhir Shah's areas of interest is stroke, neurodegenerative disease, and epilepsy. Our co-director also needs no introduction, Dr. Lakshmi Narasimhan. Sir is Director and Professor Institute of Neurology at prestigious Madras Medical College, where he was also a student and now he is heading the whole department. Many awards and achievements to Dr. Narasimhan credit. Paltussi Advisor from AN, A.B. Baker Award from as a Global Best Teacher, Best Paper Award at American Academy of Neurology, Global Elsevier Atlas Award. He is also in the Executive Committee member of World Federation of Neurology, Liaison Officer of World Federation of Neurology, has made immense contribution in the field of neurology, and that is evident. Sir, may I invite you to initiate the whole process?
Lakshmi, sir.
Can you hear me? Can you hear me?
Yes, sir, we can.
Yeah. I take
Sir, yes, now.
and sir is not introducing. Sir is okay.
Dr. Lakshmi, please go ahead.
Okay, sir. Okay, sir.
Please.
I take immense pleasure in introducing Dr. Subhadeep Gupta, postdoctoral trainee in the Department of Neuromedicine, IPGMR, Kolkata, and welcome to you, Doctor. And Dr. Arpan Datta, postdoctoral trainee, Department of Medicine, IPGMR, Kolkata, and Dr. Souvik Dubey, Assistant Professor, Department of Neuromedicine, IPGMR, Kolkata, and Dr. Alak Pandit, Professor, Department Neuromedicine, IPGMR, Kolkata, and Dr. Biman Kantirai, my friend and my very close friend, and we have traveled in neurology together. And I share a lot of pleasant moments with Dr. Biman Kantirai, one of the outstanding teachers in Kolkata. He also is attached to the Bangalore Institute of Neurology, the premier institute of neurology in Kolkata. Dr. Biman Kantirai, Professor of Department of Neuromedicine with IPGMR, Kolkata, and is well known across the country. His area of interest being dementia, and he is the organizer of this program. I welcome you, Professor Biman. Looking forward to listening to all of you. And over to Dr. Biman to take over the proceedings.
Sir, sorry, you need to unmute.
Unmute, sir.
Sir, please unmute yourself. You have, yes, now it's okay.
Yes. Thank you, Dr. Lakshmi, for your nice introduction. Sir, I also convey my sincere regards to Dr. Sudhir Shah. And now I will request our third year resident, Dr. Subhadip Gupta, to present the case. Dr. Subhadip.
Am I audible?
Yes, sir.
Am I audible?
Yes. Your slides are visible. You are audible. Go ahead.
Good evening, teachers and colleagues. Today I am going to present my case on rapidly progressive dementia, expect the unexpected, from Department of Neurology, Bangalore Institute of Neurosciences, IPGMER. A 25-year-old male, private tutor by occupation, graduate, right-handed, and the case was informed by his brother. Initially, in the month of December 2019, his students complained that he used to switch from one subject to other. For example, from English to physics, from chemistry to mathematics, and on questioning, he used to get irritated. While taking class, often he used to leave the classroom. If he is asked where is he could not tell, and even if he could reply, he used to say wrong location. But he never lost his way inside or outside his house. He also had difficulty in naming objects. Though he could specify the function, for example, give me that thing with which I write, could not tell chalk or pen. Give me that thing from which I drink water, could not tell bottle of water. Though in the initial few months till the month of April, his reading and writing remained normal. He used to jumble up and schedule multiple batches on the same time, and he never maintained a diary. He used to take more time in performing daily activities in the form of taking bath, doing pretty household work, turning on the bed. He used to take more time in reacting to questions as well. At times he could not answer, and at times he used to answer with much difficulty and after some time. As the days progressed, he also used to forget his parents' name. However, he could identify them. On questioning, he could not tell year of passing secondary or higher secondary examination. The symptoms progressed relentlessly. In between, he attended the outdoor department of other medical college of same city, but there was no relief. However, at this point, he could not pursue his job anymore. He was admitted for evaluation in Calcutta National Medical College. The information we could retrieve from the discharge that there was multi-domain cognitive dysfunction, though not specified. Deep tendon reflexes were brisk in all 4 limbs, and there was bilateral positive Babinski sign. In the month of February 2020, we got another medical report in the form of a OPD ticket where it was noted that there was no improvement in his illness. The basic ideal was preserved, but patient's cognitive status declined further. Patient had one episode in August 2020 of staring look followed by turning of head towards right side, and after that there was tonic-clonic movements of right upper and lower limbs. Patient was unresponsive to verbal commands. It continued for 45 minutes. Though there was no history of involuntary micturition or defecation, patient remained in altered sensorium for next 2 hours. He was managed in the ER and was discharged, and on the next 1 month he was well controlled and had no episode of seizure, and he was put on oral antiepileptic drugs in the form of levetiracetam. Over the next few days after discharge from the emergency department, he became aggressive. He used to roam about without wearing dresses. He used to bathroom without closing the door. Inappropriate gestures towards the females of neighborhood were also noticed by his family members. He had increased craving for foods, particularly sweet food. He used to remain untidy. He did not flush, pen, or wash himself even after passing the stool. In the month of September 2020, he had 4 to 5 episodes of seizure in cluster of similar semiology as described before, each lasting for 15 to 20 minutes with 5 to 10 minutes interval in between. However, the patients remained unresponsive throughout the episode of 1.5 hours. That could not be controlled in the emergency, and that for the first time we saw the patient as the patient was admitted to our institute. The status was controlled by medication. However, over the next few days, he also had few episodes of right-sided twitching of face, but not the full-blown picture as described before. Post-recovery, when the level of consciousness became normal, we found that he is moving his right side less, he is unable to understand or speak, and he is unable to expel desire for urination or defecation. He had no history of headache, neck pain, fever on and off or preceding the first episode. There was no history of anorexia or weight loss, no history of rash, joint pain, oral ulcer, abnormal posturing, no history suggestive of cranial nerve involvement. There was no abnormal sensation or sensory loss. He is not history of any known addiction, prolonged medication intake prior to the illness, exposure to any toxin, or there is no family history of any neurological or psychiatric illness. On examination, patient was conscious. He could not speak or follow our command. Whatever we can see, the extraocular movement were apparently normal. People were normal in size and normally reacting. There was no facial asymmetry. Jaw jerk was brisk. He was moving his all 4 limbs, but somehow the movement in the right side of the body was less compared to the left. There was spasticity in all 4 limbs. Deep tendon reflexes were brisk. Plantar were bilateral extensor, and frontal release signs were present. With treatment, his seizure got controlled, but there was no improvement in the cognitive function. Patient was discharged. However, few days back, patient was again admitted with 1 episode of focal seizure. Patient was admitted in the post-ictal confusion state. His sensorium improved with treatment, but he remained aphasic with right hemiparesis. To summarize, a 25-year-old male graduate, private tutor by occupation, presented with rapidly progressive cognitive decline, slowness of activities, focal seizure with impaired awareness, right hemiparesis with global aphasia, upper motor neuron sign in all 4 limbs with brisk jaw jerk, and frontal release times. Symptoms progressing relentlessly over 1 year with severe impairment of activities of daily living, both in the form of basic and instrumental. For the discussion of the case, I will now call upon my colleague, Dr. Arpan.
So now I will try to analyze this case from history and examination, and I will discuss it symptom by symptom and sign by sign. So coming to the first symptom is the inappropriate changing of topics while teaching. So this can occur either due to impaired attention, impaired planning and organization, or impaired working memory. Now coming to the impaired attention part, it is actually an impairment of, it can be an impairment of the sustained and selective attention, which is controlled by the dorsal attention network with important nodes in the frontal eye field, premotor cortex, posterior parietal cortex, and subcortical connections. We know that there are two important parts of the attention network. One is a ventral attention network, which actually orients us to the salient and relevant stimuli. And the important nodes involved in this part are the ventral prefrontal cortex and the temporoparietal junction. Another one is the dorsal attention network, which orients towards goal-directed focus of objects. And usually the dorsal attention network keeps the ventral attention network suppressed during our goal-directed activities. So next substrate comes the impaired planning and organization, which is a part of the central executive network, which has important nodes in the dorsolateral prefrontal cortex, posterior parietal cortex, and their subcortical connections. This is a depiction of that frontoparietal control network. So another possibility what we kept is impaired working memory, which also involves the central executive network. This is the dorsolateral prefrontal cortex as in the central part of this connection. Now the next symptom was getting irritated on questioning. The possibilities could be either lack of inhibitory control, which is due to damage of the orbitofrontal circuit involving the cortex and subcortical connections, or it may be due to lack of insight. That is, the teacher was unaware of his illness, so he gets irritated when he is told anything about that he is teaching abnormally or not. And this lack of insight is actually failure of disengaging our internally oriented thoughts towards the externally oriented goal-directed activities, which is actually there is a balance between the default mode network, which has important nodes in the medial prefrontal cortex and the posterior cingulate cortex, and the balance is with the central executive network. And the network which maintains this balance or the switch is the salience network, which has its important nodes in the insular cortex, mainly the right insular cortex, and the anterior cingulate cortex, mainly the dorsal ACC. So the lack of insight can be due to failure of this disengaging. Another possibility can be that the teacher, he doesn't want to admit his illness in front of his students. This could also be a possibility. Now, the third symptom was leaving classroom in the middle of teaching. What can occur, what may be the reason is, there can be, it can be due to lack of inhibitory control, again due to the impairment of the orbitofrontal circuit. It can be due to wandering, which we observe in frontal lobe damaged patients. Can it be akathisia or dissociative fugue or focal onset seizure with impaired awareness? But there are no history of such restlessness while teaching inside the classroom. And also there is no history of, or maybe no definite history of amnesia for the event, which goes against these possibilities. Coming to the next symptom, refusing to tell his location and telling wrong location on occasion. It can occur due to lying, which we see in when there is damage to the prefrontal and anterior cingulate cortex. It can be due to topographical disorientation, that is the patient is unaware of his current location, and that's why he couldn't tell his location. So this disorientation can occur due to damage of the non-dominant parietal lobe. It can also occur, it may also occur due to impaired memory, that he has forgotten the name of that location. It can be a possibility, or maybe it can be due to anomia. That is, he is unable to tell the name of that location, and when he is trying, he is occasionally telling the wrong name. Now, coming to the further symptoms, there is difficulty in naming objects, which we were discussing in the previous symptom, that there can be a possibility of anomia. Now here, when we analyze difficulty in naming objects, there can be three possibilities. One may be due to anomia, one may be due to defective object recognition in the form of agnosia, or there may be impairment of the semantic knowledge or the object knowledge. So here, what I hear from history, that the teacher could point towards chalk or pen, and he knows what to do with that. That is, he has preserved object knowledge, and he can point towards that object, which rules out agnosia and impairment of semantic knowledge, and leaves us with anomia, which can occur due to impairment of the posterior part of the perisylvian region of the dominant hemisphere. In his case, as he is right-handed, most possibly the left hemisphere. Although pure anomia has less localization value. So this is the perisylvian network which I am talking of. Now coming to the next component, that is jumbling up and scheduling multiple tuition batches at same time. So this can occur either due to impairment of the memory, that is the episodic memory, or can be due to impairment of planning and organization. He didn't maintain diary. So if he would have maintained diary, then we could say that this may be more likely a problem of impaired planning and organization. But as he didn't maintain diary, so there is the memory comes in play more in case of remembering the schedules of the tuition batches. So impairment of episodic memory, it can occur either during registration, which requires full attention, mainly involving the dorsolateral prefrontal cortex and the posterior parietal cortex and their connections. The next impairment can be during the encoding and consolidation, which is a function of the limbic and paralimbic regions. Third can be due to the impairment of the storage in the paralimbic regions and neocortex, or it can be due to impairment of the retrieval process, which involves the prefrontal, anterior and medial temporal lobes. Here, more recent is the memory, more it is dependent on the limbic and paralimbic regions, and more older memories, decades or years old, it is independent of the influence of the limbic and paralimbic regions. So schedule of the tuition batches comes in more of a recent type of memory. And impairment of planning and organization, as we have already discussed previously about the central executive network. This is the Papez circuit and the limbic structures which are involved in the memory process. Now, the other symptom was taking more time to act and also react. So when we analyze this thing, that is taking more time to act, it can occur either due to bradykinesia, with or without bradyphrenia. It can occur due to weakness, increased tone, incoordination, lack of motivation, either in the form of apathy or depression, or it can be due to a slowness of hypothyroidism. Now, if we consider that whether we have to consider whether the patient was slow only during doing any motor act, or whether he was slow in doing all kinds of activities and all kinds of one thing which it was mentioned during history, that he was also slow to react to questions also. That is, there is not only slowness in during motor performance, but also there is slowness during thinking process. So this part rules out weakness, increased tone, and incoordination, because in these three cases, the slowness will be during only the motor action, but not during the thinking process. So here our possibility remains the bradykinesia, including bradyphrenia, or maybe due to lack of motivation, or maybe due to hypothyroidism. So this is the circuit of the this is the motor circuit, which involves the cortex, the cortico-basal ganglio-thalamocortical circuit, the cortico-pontocerebello-thalamocortical circuit, which is important for smooth motor performance. Can be due to damage in any part of this, but as there is also bradyphrenia, basal ganglia and its connections, that is the cortico-basal ganglio-thalamocortical loop, is most likely involved. Now, coming to the next symptom is that he used to forget his parents' name, but he was able to identify them. It can occur due to anomia, or maybe due to impaired memory. So if we consider anomia again in this case, we have already said that it can be due to damage of the posterior part of the peripheral region of the dominant hemisphere, or maybe non-localizing fellow. And also there is another history of forgetting years of passing important examinations, which are actually decade-old events. And this can occur due to impairment of the autobiographical memory, particularly in the part of the storage either or retrieval, because encoding, registration and encoding has already been done, and the immediate storage and retrieval, which is a component, the recent storage, recent retrieval and storage, which is a limbic structure and paralimbic structure dependent the substrate, is not involved in this case, because these are decade-old memories. So in this case, if there is any damage in the storage part, so there may be neocortical damage, or if there is impairment in the retrieval part, then it can be due to the prefrontal and anterior temporal cortical malfunctioning. Now there is one episode of unresponsiveness with head turning towards right and tonic-clonic movement of right upper and lower limbs. This is a focal seizure with impaired awareness, which could be due to the problem of left frontal lobe. And there are also symptoms of aggressive behavior, some disinhibition features like aggressive behavior, roaming naked, using bathroom without closing door, inappropriate gestures towards opposite sex, food craving. This can occur due to damage of the orbitofrontal circuit. Now, food craving, when we consider food craving, this can occur due to a problem or impairment of the reward network, which also involves the orbitofrontal cortex and with important connections with the ventral striatum, ventral tegmental area, and hippocampus. But what is seen in frontal lobe patients, that is, the disinhibition is more important in their food craving rather than an impairment of the reward network. So then again, the untidiness and lack of shame occurs in prefrontal cortex damage. Then coming to the examination, what we have found is global aphasia, which is due to damage to the perisylvian region of the dominant hemisphere, which is left in this case. Right hemiparesis, as there is associated global aphasia, and also there is no associated cranial nerve involvement. So most likely it is due to Mainly the possibility, as there is aphasia, it is due to involvement of the motor cortex, the left motor cortex, but we have to keep the possibility of subcortical structures also until and unless we are seeing the images. So there was UMN sign in all 4 limbs with brisk jaw jerk, localizing it to bilateral pyramidal tract involvement above midbrain. And there were frontal release signs indicating frontal lobe involvement. So after analyzing, there comes the possibility of more or less 4 neuroanatomical sites, which are the bilateral frontal lobes and their subcortical connections, bilateral temporal lobe and subcortical connections, left perisylvian region, with or without bilateral parietal lobe. And the possible pathologies in this case, pathologies and etiologies, which we have considered, that there is from history there is multifocal involvement and asymmetric involvement, with the main substrate being progressive cognitive decline along with seizure and a right hemiparesis. So we kept the vascular pathology as the first possibility, and among that the vaso-occlusive diseases or the genetic vasculopathies are more likely than the others. Now, coming to the infective possibility, although there were no systemic symptoms or history of fever or headache, but still in a young male we have to consider, in presence of such multifocal complaints and cognitive decline, the possibility of HIV and PML again, which can occur as an opportunistic infection in HIV, but can also occur in immunocompetent patients also, and tuberculosis, mainly in the form of multiple tuberculoma. Again, when we consider progressive cognitive impairment, seizure, bilateral UMN signs, then we think of leukodystrophies, but there is some asymmetry in this case. So if we think of leukodystrophies, we have to think of such leukodystrophies which can be asymmetric. So in that case, the CADASIL and CADASAL, these entities become more likely, because they also can cause vascular stroke-like episodes like that. So these 3 entities will also come in the vascular etiologies also, and also in the leukodystrophy group. So some other possibilities we kept, mainly because they are treatable causes. One of them is mitochondrial, one is demyelination, mainly in the MOG associated demyelination, which can present with such multifocal presentations. Among the inflammatory group, Sjogren, Behçet, sarcoid can mimic different neurological diseases, and they are treatable. So we have kept them in our mind. Among the autoimmune causes, which can be either paraneoplastic or non-paraneoplastic, the predominant involvement is in the medial temporal lobe. But our history and analysis doesn't proceed in that way. It has involved mainly in the fronto-subcortical circuits to start with, and the predominant burden lies there only. So if at all any autoimmune disease can progress like that, there can be some rare possibility of GABA-B associated autoimmune encephalitis, or maybe anti-TPO associated autoimmune encephalitis. And we have also kept the possibility of neoplasia in the form of CNS lymphoma or secondaries, which can have such multifocal lesions. So for further, so now we go to the investigations part, which will be discussed by Subodhip.
During his initial presentation, a CT scan was done in the month of December 2019, which shows both anterior and posterior white matter changes, but the burden of the disease is clearly more on the left side. After 2 weeks after his admission, a MRI brain was done, which showed bilateral but asymmetric and large, fluffy white matter hyperintensities with early involvement of the U fiber. They went for contrast images as well, which showed there is nodular contrast enhancement in bilateral frontal lobe. And I want to mention here that this MRI report was reported as a infective encephalitis. Probably for that reason, the treating clinician went for a CSF study, which came out to be normal, and workup was done for leukodystrophies in the form of metachromatic leukodystrophy and GM1 glycosidosis, and both the enzyme activities of leukocyte came to be normal. Genetic disease possibility kept in the form of CADASIL were also evaluated in that institute, which came out to be negative. Now, when we received the patient in the month of September, the MRI showed there is grossly asymmetric involvement of the left hemisphere, and in this image, I want to highlight that there is considerable bilateral anterior temporal lobe atrophy with significant signal changes in both the temporal lobe. Now, here also in the FLAIR image, we depict the same, but I want to describe the coronal image where there is clear-cut involvement of the frontal region, the arcuate fasciculus, and the temporal lobe, explaining the global aphasia as it involves whole of the perisylvian network of speech. And during that event, when we carefully looked at the DWI image, there was an infarct in the left insular region and posterior limb of left in internal capsule. At this point, we also want to highlight that more on the left side, but present on either side, microbleeds in the cortical region. We went for a CT angiography, and it came out to be normal both at the level of neck, arch of aorta, and at the level of brain. Now, we went for other investigation in the form of routine parameters like complete blood count, liver function test, renal function test, electrolytes, serum ammonia, all came out to be normal. As anti-TPO antibody disease was kept as a possibility, we went for that. It came out to be normal. The viral panel in the form of hepatitis B, C, and HIV were negative. Chest X-ray, ultrasonography, whole abdomen, Mantoux test if TB is kept as a remote possibility. Serum ACE for sarcoidosis, ANA and ENA profile, and ANCA, MPO, PR3 all came out to be negative. The CSF study, which did for specific investigations like oligoclonal band, IgG index, came out to be negative. Serum and CSF lactate came out to be normal. The autoimmune encephalitis panel, which is done in our institute, encompasses NMDR antibody, GABA A, GABA B, and VGKC panel, which came out to be negative, and the pyeloneoplastic panel. We did not stop with that. We went for a PET scan. The serum anti-aquaporin 4 and anti-MOG antibody was also negative. Chest virus PCR was also negative. Now, during his last admission, in the T1 image, we can see bilateral considerable brain atrophy more on the left side. There is atrophy of the white matter already, and there is widening of CSF spaces, and there is gross involvement of the periventricular areas at present as well. When we went for the MR spectroscopy, there was mildly elevated choline peak. However, we considered mitochondrial diseases, but no lactate peak was seen. A PET scan was done, which failed to reveal any neoplastic process in the body, but demonstrated severe hypometabolism in the bilateral temporoparietal lobe, left inferior frontal region, anterior cingulate region, basal ganglia, and right cerebellar hemisphere. Now, for critical dissection of these clinical aspects and refined diagnosis, I would like to welcome Sir Dr. Shobhik Gupta.
Good evening, teachers and my juniors. After nice elaboration of case by Dr. Shubhadeep Gupta and extensive analysis of the probable anatomical localization by Dr. Arpan Datto, my duty is to first to make the multi-domain cognitive impairment, to discuss it in simpler way, and to cut short the list of differentials. So what we left after the history, clinical examination, and relevant investigation, we left with the young male patient with multi-domain cognitive impairment, recurrent seizures, and bilateral corticospinal tract findings. So first, I have to dissect that what does multiple cognitive domain impairment mean? If we look it carefully, then we can see clearly that the multi-domain cognitive impairment, we divide it into simpler way. It's cortical involvement, or it is subcortical involvement, or it is mixed involvement. If you look into our case in detail, then we can observe that in our case, the cognitive involvement starts from the attention difficulty, later followed by delayed information processing speed, executive dysfunction, some form of behavioral abnormality. Later memory takes the upper hand, memory impairment, and ultimately some difficulty in naming persists in our case. So in gross, this is the basic multi-domain cognitive impairment in our case. To analyze it further, attention deficit, delayed information processing speed, executive dysfunction, and some form of behavioral impairment, we can impart this sort of impairment to the frontal subcortical network. And if we go with the memory impairment and for the naming difficulty, and later one stroke-like episode which led to aphasia, we can localize it over the cortex. So in our case, multi-domain cognitive impairment, to start with, it was subcortical in nature. Later, some cortical features supervene. That's why our case multiple cognitive impairment pattern is mixed subcortical and cortical. One thing is most important, that in case of cognitive impairment, where multi-domain cognitive impairment is present, there we need to decipher whether subcortical impairment, from which one is it to start with, subcortical or cortical. Because in later subsequent course of involvement, the involvement of vice versa way, that is cortical to subcortical involvement and subcortical to cortical involvement, later haze the picture. That's why our case is clearly subcortical involvement and later cortical involvement, leading to mixed involvement, subcortical and cortical involvement. And deciphering one by one, if I go with the attention problem, then Dr. Arpan already mentioned about the possible localization and anatomical localization, but I want to mention only a single network, that is large network in the brain. Large network in the brain consists of default mode network, and only a single substrate I want to highlight is the PCC, posterior cingulate cortex. Only single node. This is very much important. With the help of ventromedial prefrontal cortex and angular gyrus or inferior parietal lobule. And second is the salience network. Only single key player we have to know, that is bilateral insula. Though recent studies showed that right insula is more important in salience network. And number third is the central executive network, that is chiefly governed by dorsolateral prefrontal cortex. That's why this network, larger network, is in complex interplay by the way that when salience network is activated, then it inhibits the default mode network. And what does default network plays? Default mode network actually responsible for the inner thoughts, imaginations, and mental simulations. So any disturbance in the default mode network will lead to the thought disorders. And in case where salience network, when we target towards to an external stimuli, which in colloquial language is known as attention, when salience network is activated, it by counterplay, it inhibits the default mode network. And number third, the salience network activates the central executive network or dorsolateral prefrontal cortex, by means of which the execution procedure done. And along with the activation of the dorsolateral prefrontal cortex, basically that also leads to the activation of the working memory and on-holding memory. And that is the start of the basic on-holding memory, working memory, further leads to the short-term memory, and then ultimately it will go into the long-term circuit. This is the multi-domain cognitive impairment in our case. And later in my course of the talk, I will cut short the list of the differentials. So coming one by one, in this case, as the case having much more attention deficit, that's why the cognitive test, detailed cognitive test could not be done. But if the options were there, if then some tests could have been done to make it easier, like the attentive listening condition test, when it presents the word sequentially, then we can get useful information from about the attention. Number second, dichotomically, when male and female voice presented simultaneously, and if patient can able to discriminate between those voices, then we also can get a clue about the listening attention. Number second, information processing speed, which I have earlier mentioned, that bilateral subcortical networks usually involves in maintaining the information processing speed. Recent studies showed that though bilateral for subfrontal networks are responsible, but right basically cortico-caudate prefrontal network is more responsible than the left. Behavioral circuit, I already mentioned, Dr. Orpon already have mentioned that behavior is chiefly controlled by the paralimbic system with the negative inhibition of the frontal lobe through the frontal limbic connections. So anywhere, either frontal lobe syndrome or paralimbic problem along with amygdala destruction, or the connections that lead to the behavioral problem. In our case, the behavioral problem in such a way that it took place, we can localize it over the orbitofrontal cortex and its subcortical connections. So to make it simple, that executive dysfunction which present in our case, that may stem from dorsolateral prefrontal cortex, and ultimately it may also could have been involved caudate, globus pallidus, or thalamus, but detailing is not required. Dorsolateral prefrontal cortex along with subcortical connections. Apathy, which we got in our case, probably stem from medial frontal cortex involvements with its nucleus accumbens, again through the globus pallidus and thalamus. Disinhibition, which I have earlier mentioned, that may stem from the orbitofrontal cortex. Working memory, that was also impaired in our case. And the simple fact is that working memory is totally depend upon the on-holding memory and central executive function to be activated. But before central executive to be activated, that needs help of the two side-by-side loops to be activated. One is the auditory loop, that is known as phonological loop, and another is our visual loop, that is visuospatial sketchpad. By means of two important sensory inputs, central executive is activated. But after the activation of the central executive, it is not sufficient. That is coupled with the time and order sequence known as the episodic buffer that will ultimately lead to the formation of the long-term memory. So we can test we test our patient by the serial subtraction test and serial subtraction. That is very important, usually done by 100-7 stepwise. 5 steps are there to measure, to calculate, or to appreciate problem in the sustained attention, calculation, or in working memory. Coming to the memory part, this is very simple and taken from the Meshulam that memory formation. So first is the registration of the information through various sensory inputs, along with the activation of the neocortex. That's why we are human being. Then coming to the short-term memory and working memory, chiefly, which I have earlier mentioned, central executive or frontoparietal network is very important to form the short-term memory. And then encoding and consolidation totally depends on the limbic and paralimbic cortex. And encoding, again, depends upon the spiking of the neurons and again mediated by the long-term plasticity. And storage formation chiefly depends upon the cortical reserve and then retrieval of the information. Once it is stored deeply into the cerebral cortex, it doesn't need, it retrievals the backward pathway via hippocampus. It may directly retrieve over the cortex. So to test it in simpler way, the 4 unrelated word test that we can do, if patient there is problem in immediate repetition, then it indicates that there may be the problem in the registration or working memory. If patient can't recall, then we have to give the cues by means of 3 usual ways. Number is phonemic similarity, by means of semantic similarity, and by means of contextual similarity. If patient can able to answer, then we can localize it. There is some sort of retrieval defect. Second, if patient can't able to answer, then we have to tell the name of the words in amidst the series of the words. And if patient can identify the words that he already told, then it implies that patient recognition is normal, but there is some problem in recollection or familiarity. And it is worth noting that in case of familiarity, the first mapping pathway is activated, and in case of recollection, slow searching pathway is activated. So our patient also have some sort of naming difficulty. Dr. Orpon already have mentioned it, but to summarize it in very simpler way, that it could be when a person present with the naming problem, then it could be anomia, it could be object agnosia, it could be semantic dementia. And if only a simple word is that, if it's modality specific, then it went in favor of object agnosia. And if it is non-modality specific, then it goes in favor of semantic processing impairment. And if patient can able to perceive the size, shape, color, and location, then it is very lowered down problem known as the apperceptive agnosia. And if there is some problem in the lexical pathway, then patient may present with anomia or paraphasic errors. Then the next part is to cut short the differentials. If we think in the line of demyelination, then points in favor in our hand is the classical constellation of seizure, cognitive impairment, and upper motor neuron signs, which I mentioned earlier. But important is that there are 2 points that against the demyelination is the asymmetry. As we all know that in case of demyelination, point-to-point similarity, point-to-point symmetry is very important in imaging. Also, later part, MRI is characterized by the presence of the microbleed. That's why demyelination possibility, we want to keep this possibility lowered down of our differential. Number second, genetic vasculopathy. This is a high probability in this background because the points in favor weighs out the points against, because the clear-cut presence of stroke-like episode that will lead to right hemiparesis and global aphasia later on the course of the disease, sharp asymmetry, and evidence of microbleeds in MRI. Points against, the seizure with recurrent status. To start with seizure and recurrent status without any significant family history and headache makes it quite somewhat unlikely, and the large fluffy opacities and involvement of the U fiber early in the course also stand against genetic vasculopathy, though after all the relevant investigation, if one possibility we have to keep to the top of the list, in my opinion, this part, genetic vasculopathy, we must have a clear-cut insight into that part, and we have to keep it over the top of the list. Demyelination points against, how to is the points in favor. Only one point is the points in favor, that floppy lesion with contrast enhancement, that usually go in favor of secondary demyelination or primary demyelination non-MS. However, progressive disease, cognitive decline to start with, seizure as presenting manifestation, normal CSF studies, seronegative profile, and evidence of microbleed in MRI stand against demyelination. Infection is a possibility, as Dr. Subhadeep showed it earlier, that contrast enhancing lesions are there, multifocal, so it is not unlikely that a granuloma is underlying that edema, but however, some points are against it, that patient is immunocompetent, chance of HIV, PML related infections are less, no history of fever and headache, and CSF was normal, and all the infection screenings were negative. MELAS, again, it's an important entity to be emphasized. However, MELAS, which we all know that mitochondrial disease usually involve gray matter more than the white matter, as this is basically a energy failure. But after localization, after investigation, relevant investigation, we clearly see it that our patient having predominant white matter disease, that's why MELAS also to be kept lower down in the list. So where do we stand? This is asymmetric leukoencephalopathy with relentless progression in form of rapid cognitive decline, bilateral corticospinal tract involvement, and difficult to control seizure. Routine and special investigation came negative. NOS3 genetics, targeted genetics, NOS3 earlier sent, but that also came negative. So my question is that, can it be some other genetic disorder, or is there some role to play in the genetics per se? Last part is that the most fascinating part of this case is ultimately almost clueless. We done exome sequencing, and it came out to be positive in the form of heterozygous mutation in exon 32 of NOS3. And the next part, what is the implication and importance of genetic testing and how can it be done, will be elaborated by no other than Professor Alok Pandit, our teacher and also clinical neuroscientist and specific interest in genetic part of the neurological testing. I would like to invite Professor Pandit for elaboration of the speech.
Good evening, everybody. Now we're having a young male patient with multi-domain cognitive impairment, repeated seizure and situs, along with hemiparesis. And almost all the investigation has been done, but we are still in a dilemma. What is the diagnosis? At this point, we have a data that is a mutation, heterozygous mutation in exon 32 NOS3 gene. But this is not the typical area of CADASIL mutation. So, and the classical mutation site done by PCR is also negative. So at this point, should we consider still as a genetic vasculopathy in the form of CADASIL, or we should think otherwise? At this point, we have to decide whether we should go for further testing in the form of for tissue biopsy, stereotactic biopsy to reach a tissue diagnosis, or we should interpret our current data in genetic testing, that is a new mutation in the NOS3 gene. So when we order a genetic test, we should have a basic idea regarding genetic testing. Genetic diseases can be caused by chromosomal aberration from like duplication, aneuploidy, balance dislocation, and balance translocation to point mutation. So we have to identify these genetic diseases by different methods. We have some basic tests starting from chromosomal karyotyping to newer generation sequencing in our hand. But how to order these tests, we should have a clear about this regarding this. So in every case, we should have a detailed history and clinical examination. From that, we have to build up a list of differential as we did in our case. followed by baseline investigation and other special investigation to cut down our or shut down our differential, as already we have done. Now, with this knowledge, if we can have a known phenotype which is likely to be caused by single genes, we have different options like single gene newer generation sequencing, Sanger sequencing, or RT-PCR. Now, if we do we initially did RT-PCR. The advantage of RT-PCR is less costly, but problem is that RT-PCR can identify only the known defect. Already those mutations are known to cause this particular phenotype. This RT-PCR can detect only this type of mutations. But if there is a de novo mutation in that gene, the RT-PCR cannot detect it. So we have other options like Sanger sequencing, but it's costlier. But we can detect the already known old mutations, but also it also detect the newer mutations. And single gene NGS also, new generation sequence also can do this, but these are more costlier. So in our case, we did RT-PCR, which came to be negative. Now, if we suspect some known phenotype, if we suspect some multiple genetic diseases, like if a patient comes with dystonia or extrapyramidal syndrome with cognitive impairment, the case may be Wilson, the case may be NBIA. So we have to order for a multiple gene sequencing. In that case, we have in our hand the multiple gene newer generation sequencing and multiple RT-PCR. The advantage and disadvantage, like already have discussed. And if we cannot identify a particular phenotype, we have in our hand clinical exome sequencing, whole exome sequencing, and whole genome sequencing. Clinical exome sequencing, we can detect already those mutations which are those genes which are already known to cause some diseases. We can search all the genes. We can detect all the already known mutations and new mutations, but cannot detect. The problem is that it is costly, cannot detect tiny nuclear repeat sequences and new genetic defect in a new gene. To overcome this problem, we can do whole exome sequencing. This can detect even newer mutation in a new gene, but cannot detect the tiny nucleotide repeat sequence results. To overcome this problem, we can go for whole genome sequencing, or particularly for tiny nucleotide repeat sequences, we can go for tiny nucleotide PCR, tiny nucleotide repeat PCR. So this is our basic idea how we can approach a genetic test. In our case, these are I have already discussed. In our case, we have a report, that is RT-PCR report, notch mutation detection for CADASIL comes to be negative. But the fallacy of the test is that why this came negative? The case became negative because this PCR is only done for exome 3, 4, 5, and 6, which is the common area for CADASIL, and the usual mutations in the cysteine residues part of this genome, which causes structural abnormality and causes this glomerular osmophilic materials to be deposited within the vascular smooth muscle cells and causes the disease to manifest. But in our case, there is no deletion in this exome, but it's a long gene. So we go for this further testing by a whole clinical exome sequencing. And we found a mutation in the exome 32. And this is a novel mutation. They report this, when we go for a clinical genome sequencing, the reports can be like this. In our case, it is uncertain significance, but report can come in the form of, it can be benign, likely benign, uncertain significance, likely pathogenic, and pathogenic. So in our case, likely pathogenic or pathogenic mutation, which if we got this, we can term that this is a case of CADASIL. But in our, if the reports are like benign or likely benign, these mutations are not likely to cause this phenotype. But we are getting a result which is uncertain significance. What do you mean by uncertain significance? Firstly, these mutations which is detected by clinical exome sequencing, and report to have uncertain significance. We have to confirm this by Sanger sequencing because there may be false positive result in clinical exome sequencing. So this mutation to be confirmed by Sanger sequencing. And if we can confirm this by Sanger sequencing, then we have to go for screening of family members to prove that the family parents have also same type of mutation. Then you can call it likely to be pathogenic in this case. But unfortunately, in our case, because of financial constraint, we cannot go for these two testing. So what else we can do? So we can have clinical clue that it may be a genetic vasculopathy, as we have already discussed. So we go for literature and database search. Whether this is a very rare variant, it may be that there may be some reports maybe there in the literature, and which is not sufficient to came in the database of this lab, but there may be some reports. And we search for that, and we found one similar type of mutation, one single case in the literature with same mutation. Now we can go for gene expression analysis, which can be done by software. I'll go in details, or we can I can wait for reclassification in future, because we have to wait for some more cases to come to confirm that this uncertain significance mutation is causing this phenotype in our patient. This is the way how we can go further for this sort of mutations. But if we see the reports which came from this lab, that the genetic expression analysis shows that there is that these variants are probably damaging by polyphen 2 and damaging by shift and mutation tested software. So in our case, this mutation may be pathogenic, and the reference codon is also conserved across the species. So this is very important, because these softwares are predicting that this mutation may be pathogenic, and this may be the novel genetic mutation. This is for the one I have already told that there is a single case report is that. Will be the second report from our institute that this mutation is causing the variation in this variant of this CADASIL in this patient. So with this genetic background, now what is our diagnosis? We think that this is a novel mutation in a non-cysteine residue. That's why the typical phenotype of CADASIL, that is differ in this patient. CADASIL usually presents with recurrent stroke-like episode followed by cognitive decline. But in our case, initially there's a cognitive decline followed by seizure followed by stroke-like episode. So this variation for the normal course of the disease may be that this may be a novel mutation, and this mutation is in a part which is in the ankyrin repeats domain, which is an intracellular part of the NOS3. Usually we have mutation, mostly the documented or literature documented mutations in the extracellular domain. But in this patient, we have a intracellular domain mutation in the NOS3. That's why this very clinical phenotype may be variants in this patient. So we are not going for tissue biopsy at this present, and we are stick to our diagnosis that this is a case of possible CADASIL with a novel mutation. I will invite Professor V.K. Rai for his final comments.
So good evening, everybody. Now, it is my duty to give some comments, and I hope you have enjoyed whatever was told by our previous speakers, Dr. Arpan, Subodip, Souvik, and all of them have done a very comprehensive discussion on the clinical part, on the examination part, on radiological part, and as also on the genetic part. Now, when I give final comments, I think these parts have already been covered adequately: cognitive, focal seizure, CST involvement, everything. Since this is this program is dedicated mainly for our DM residents, I will try to highlight some important issues whenever we come across asymmetric white matter hyperintensities in MRI. Now, whenever we look at any such MRI where the patient is having white matter hyperintensities, we have to approach in a very structured way. First of all, you have to ask you few questions. The first question should be, is it a case of hypomyelination or dysmyelination, or is it a case of demyelination? Now, if you want to differentiate dysmyelination from demyelination from the MRI picture, you have to depend on T1 weighted image. If you look at T2 weighted image, the white matter will look hyperintense both in case of dysmyelination or demyelination. But in T1 weighted image, the demyelinating lesions look hypointense, that is black, whereas in case of dysmyelination, the T1 weighted image looks either isointense or hyperintense. So when you look at MRI picture, to differentiate between these two entities, you have to depend on T1 weighted image. Now, once you get these white matter hyperintensities, the next point you have to decide what is the distribution of the lesion. Is it focal, multifocal, or confluent? Is it symmetric or asymmetric? And where is the location of the abnormalities? Frontal, parieto-occipital, periventricular, subcortical, diffuse cerebral, or it is involving the posterior fossa. So you consider all these points when you are describing white matter hyperintensities in the MRI. And the next important issue, you have to look for U fiber involvement. And next is whether there is any contrast enhancement, and also look for any hemorrhage or calcification within the lesion. If you take into account all these points while you are assessing an MRI hyperintensity, I think you will get answer to diagnosis in most of the situations. Now, this picture shows the different patterns of involvement, as I have already mentioned. And depending on the different patterns, some of the specific diagnosis comes first to our mind. Suppose a patient has predominant parieto-occipital involvement, you think of adrenoleukodystrophy. A patient has predominant frontal involvement, you think of X-linked adrenoleukodystrophy or metachromatic leukodystrophy. Adult age presentation, they sometimes start with frontal pattern. If there is brainstem involvement, you think of Alexander disease. If there is periventricular involvement, you think of metachromatic leukodystrophy. So depending on the site of involvement, some of the differential diagnoses come first to our mind. And regarding symmetry and asymmetry, as it was as has been already discussed, if you get symmetric involvement, you think of leukodystrophy. But in the leukodystrophy group, if you otherwise from the clinical history you are thinking this may be a case of leukodystrophy, but there is asymmetric involvement from the beginning, you always rule out the possibility of genetic vasculopathies and also megalencephalic leukoencephalopathy with subcortical cyst, that is known as Van der Neef disease. Now, these are the typical MRI pictures of some of the common white matter lesions. In CADASIL, you always search for any lesion in the anterior temporal lobe and in the external capsule. In ADEM, the most important points are you get large fluffy lesions. There may be involvement of gray matter as well, and there may be contrast enhancement or may not be contrast enhancement, and the clinical course is monophasic. So these are the pictures, MRI pictures of ADEM. When you consider MOG antibody disease, one striking finding is that you may get brain atrophy, you may get large fluffy lesions, and there may be involvement of the brainstem as well. Sometimes it is difficult to distinguish long-standing multiple sclerosis lesion from leukodystrophy. In that cases, if there is involvement of corpus callosum or early involvement of the subcortical U fiber, the possibility of multiple sclerosis comes first in the differential diagnosis. CNS vasculitis, particularly primary angiitis of CNS, can have different type of MRI picture, and frequently they present with cortical or subcortical edema. There may be variable contrast enhancement, and in these pictures you predominantly get white matter, sorry, hyperintensity in the subcortical white matter, also in the gray matter, cortical gray matter, but you may also get periventricular diffuse white matter hyperintensity. This is another picture of primary CNS angiitis. And whenever you suspect primary CNS angiitis, don't forget to look at GRE images where you can get evidence of bleed, and you can also get contrast enhancement as we got in this this particular case. Regarding mitochondrial encephalopathy, there may be different type of changes. There may be cerebral infarction bilateral with subcortical involvement. But one of the classical findings is that usually there is no DWI restriction. Apparently, it looks like infarction, but there is no DWI restriction, and the changes are frequently reversible. And in mitochondrial encephalopathy, apart from cortical involvement, there may be symmetrical signal change on basal ganglia, brainstem, or in white matter. So this is the classical picture of MELAS. Sometimes post-anoxic encephalopathy, they may present with diffuse white matter involvement, in addition to the usual MRI changes which I have shown in these pictures following post-anoxic encephalopathy. Binswanger's disease, that also comes in the differential diagnosis. Regarding PML, you have to remember that PML lesions are rarely contrast enhancing. There is relative sparing of the cortical ribbon. There is no spinal cord involvement. There is no hemorrhage within the lesion, and mass effects are very rare. If you consider the clinical scenario along with the MRI, along with these MRI findings, you can easily guess whether it can be an MRI picture of PML. And another differential is primary CNS lymphoma. These lesions are contrast enhancing. They may present with white matter hyperintensities, and frequently the lesions disappear following the starting of steroid, but again reappear. And another important differential is toxic leukoencephalopathy. This can be multifocal, subcortical, sometimes press-like presentation, usually no contrast enhancement, and with relative sparing of the U fiber. This is MRI picture following metronidazole toxicity. This is MRI picture of a patient having cocaine toxicity. This is MRI picture of a patient having methotrexate toxicity. So I am showing all these pictures only to impress upon you that a white matter hyperintensity is not synonymous with leukodystrophy. There are so many other clinical situations where you may get white matter hyperintensities. But you have to remember all those important points I have mentioned whenever you try to focus on in specific diagnosis. So now coming back to our case, is it really CADASIL? So I think points in favor, points against, these parts have already been highlighted by Souvik and Alok. So I am not going into details of it. And regarding the insight into molecular genetics, this part has also been elaborated by Alok. What I just want to repeat one thing. Whenever we are testing for Notch3 gene, basically Notch3 gene is encoding a protein that is the Notch signaling pathway. Now this protein has two parts. One is extracellular part, that part is the Notch receptor, and the other is the intracellular part, that part is the regulator part. As Alok has already mentioned, whatever clinical phenotype have been already described, in those cases, the mutation is in the cysteine residue. But the atypical presentations of CADASILs may occur due to mutation in non-cysteine residues. And apart from that, if there is any change in the regulator part, that is the intracellular part, that can also alter the expression of the signaling pathway, leading to different types of phenotypes which may not have been described in the literature yet. So our case may be one such case where there is some different type of mutations, not a conventional mutations which have been already described, and only in future after reporting of few more cases like this, we can have some definite conclusion. Regarding the management issue, I think there is nothing much to say. Only the important issues are cessation of smoking for headache. Preferably use sumatriptan ergot derivatives to be avoided. Avoid anticoagulant, and but till now there is no definite scope of gene therapy, but a lot of research work is going on, and rehabilitation involving multidisciplinary approach is the only thing that we can offer for this particular clinical scenario. I hope we have completed the clinical, radiological and genetic part, and now I ask, I want to have opinion of our learned panelists, and I think there will be some questions. I will request Dr. Lakshmi Narayan to continue the session.
Yes. Thank you so much, Dr. Bimon. It was a wonderful feast. Yes. I really, on behalf of the entire team, I congratulate the IPGMER team of Kolkata for really giving an excellent genetic feast on this day. As Professor Bimon told you, that I also strongly feel this could be a strong non-cysteine residue. There are actually, if you look at the NOTCH3, there's about 33 exons, and there are 33 rare SNPs where there is one very beautiful group. The group for the Charge Consortium group, the Austria worked on the entire NOTCH3 gene, where the various mutations, whatever Dr. Alok and the discussions were extraordinary. I wish the two things which I really was very impressed was instead of discussing on the location, they choose to locate the localization based on networks. That is going to be the future. There is no it is all localized these days on networks, which is going to be the future. Is the more genetics. I'm sure neurogenetics is going to be a very big role in future. Already all of us know that there are a lot of gene replacements therapies. There are the SNPs have come, and there are the oligonucleotide, nonsense oligonucleotides. All these things have come into therapy also. So we are not far away from getting a therapeutic target. As far as CADASIL is concerned, the postgraduates should understand that this is a very, very important subject, which is one of the important monogenic form of stroke, which is a non-amyloid arteriopathy, primarily affecting the brain. And as he said, NOTCH3 has a very key role in the integrity of small arteries by regulating the vascular smooth muscle differentiation, maturation, and phenotypic behavior. And what is important is it can start anywhere. There's one gentleman who, Dr. Wang et al. Said that NOTCH3 is the root cause of all small vascular disease. So in this case, as you know, the sequence is different. The cognitive decline started first, and then subsequently all these things can very well happen. So I strongly felt that this is a NOTCH3 mutation, a novel mutation in one of these exons which is described. And I think it is definitely worth publishing this case. With this, I really congratulate the team for this. And regarding the question and answers, there are a few questions to be answered. What is the difference between Sanger?
Hello, Lakshmi, we could not hear. Can you please repeat the question?
What is between Sanger sequence? Would like the one of
Hello.
you to do this.
Hello.
As Dr. Alok has already talked during his what is the difference between because Sanger.
I think Alok will answer the question.
But I
Alok.
cannot
Yeah,
hear
Dr.
you.
Alok. Dr. Alok talked about this.
Yes, I can hear you. Yeah, I cannot
Yeah, so
get
what
you.
is the student is asking, what is the difference between Sanger sequence and RT-PCR?
Sanger sequencing and RT-PCR. RT-PCR is used for known genetic diseases, single gene or polygene, known genetic disease with known mutation. They can only detect this part. Suppose there is a defect in NOS3, exon 2, and the defects are like that, the alanine replaced by valine. This only can be detected. If the same gene, if there is separate mutation, new mutation occurs, the RT-PCR cannot detect it, but Sanger sequencing can detect the new mutation also. This is the basic difference, and also there is a difference in cost also. It's a very low cost, and Sanger sequencing is more costly. But more depth analysis can be done by Sanger sequencing. It can detect all already known existing mutation as well as any new mutation that occurs in a particular patient. It can detect. This is the basic difference.
One more
Am I
question
clear?
they have asked. Yes, sir. Yes, sir. Thank you. And there's one more question. What is for mitochondrial gene? What is the genetic test you will order? I think there is a panel available for mitochondrial.
Mitochondrial whole genome sequence.
What is the specific gene
Sir,
test? you
if
will
I am allowed to answer this question, sir,
Yes.
sir,
Yes,
Lakshmi
please.
sir, if I am allowed
Yes.
to answer this question, I am Dr.
please.
Arpan Datta. So in case of what our sir has already discussed about the different next generation sequencing, one thing is that for mitochondrial gene sequencing, we have to order separately mitochondrial whole genome sequencing. So if we at all suspect any mitochondrial disease, in that case, we cannot order a clinical exome sequencing, whole exome sequencing, or whole genome sequencing. We have to specifically mention for or order for mitochondrial genome sequencing. But nowadays, there are some combined tests coming up commercially, which we also do in some cases that there is a combination of whole exome sequencing with mitochondrial whole genome sequencing. We can do that, and the combined test is less costly than the separate tests. So this can be an option.
And there's one interesting. What is the difference between purposeful wandering and purposeless wandering?
Yes, sir. As it has been discussed already. Yes, sir. It has been discussed that our first and foremost approach should start from the detailed history taking. First comes the clinics. So after that, when all the baseline and special investigations has ruled out the acquired causes, and then also in that case, if we are thinking about any genetic disease, and as Professor Alok Pandit has already discussed, if we can pinpoint to a particular phenotype or a syndrome, in which case we know some genes or maybe a particular gene. So in that case, we can precisely target our region of interest, and we can do targeted NGS. But sometimes we can go to that way, that where we stand that yes, this can be a genetic disease, but we are not much sure of that particular variant. Maybe it is a atypical phenotype, which is in our case. So in that case, sometimes it helps, but only after proceeding through the traditional way, not directly jumping into whole genome sequencing or like that.
Okay. So we started right on time, and we are closing right on time at 9:30 with the news that the next we move on to the Dayanand Medical College Hospital, Ludhiana, and Professor Gagandeep sir would take up the thing on the February 26th of 2021. And this year we have started on a grand note. I wish all of you a very healthy and a very academic year ahead. And like each one of you for giving a beautiful outlay of all this rapidly progressing dementias. And we all definitely got what is unexpected. And one of beautiful discussions for every one of you. My hearty thanks to all of you. And I now hand over the mic to Dr. Arun Chadda for his closing remarks. Thank you.
Thank you, sir. Thank you. It's really a great and wonderful session today. And we are at the end of the
Professor Sudhisha is available. So, sir, wanted to give any comments? Sir?
Oh, that's fine, Dr. Lakshmi. You have already summarized everything, and indeed, this was a wonderful exposition of clinical localization in a very different way that, as you mentioned, in the network way, which is a very important thing these days. The second thing is the radiology that was covered very well by Professor Roy. And of course, the genetic part was dissected by one and all. So I want to congratulate everybody from Dr. Gupta to Dr. Dubey to Pandit to Dr. Roy and all others who have really taken up this case. This case was very much important in the sense there were a lot of odds in this case. Normally, you would not see this kind of fulminating kind of rapid progressive dementia at a very young age like this, without any family history, without any migraine or other episodes, and having status epilepticus. So lots of odd features. Despite that, just by pursuing systematically, one can achieve the final diagnosis. That is very important lesson, how really you pursue a case and come to the final diagnosis. And despite odd things, a lot of common disease present in uncommon way, uncommon disease also present in very uncommon way. So medicine is that way like a big ocean, and we have to all keep on learning every day now and then, keep updated. As mentioned, genetics is the way forward, and of course immunology is the other part. And as far as the therapeutics are concerned, nanotechnology, robot, and gene editing, etc. So we have to keep updated as a neurologist on different fronts to give best to our patients. What is most intriguing that every time the bar standards are raised by the different participants of different colleges. This time Bean has done the same. And next time we hope Ludhiana team, the Dayanand Medical College, headed by Professor Gagandeep, a beloved friend, they would do such a wonderful session. I really appreciate all the participants for their presence. I thank Dr. Lakshmi for his massive inputs. Once again, all the participants of Bean College. I want to thank Intas team, particularly Mr. Chadda, Dr. Manoj Kumar, Dr. Heli Gadani for this endeavor. And this is something really exemplary as far as the learnings are concerned, not only for the students, but I want to spread the word that this could be equally useful for young budding neurologists as well as seniors who want to remain updated. Thank you very much. And once again, Happy New Year. We hope for the best 2021. Thank you. And with that, I invite Mr. Chadda to put a closing remark. Thank you.
Thank you, sir. Thank you. Thank you. It's really a wonderful session today. And we are at the end of the seventh session of the Secrets of Neurology web series now, which turned out to be very successful. I, Arun Chadda, Senior General Manager, on behalf of Intas Pharmaceutical, would like to propose a hearty vote of thanks to all the honorable delegates who blessed us with their presence. First of all, I would like to thank our honorable course director, Dr. Lakshmi Narasimhan sir and Dr. Sudhir Shah sir for designing such a fantastic web series on neurology, which will be very helpful to all the DM and DND students. And I would like to thanks to young neurologist Dr. Arpan Datta and Dr. Sudeep Gupta for presenting the case. Further to this, I would like to thank the entire IPGMER Neurology Department, Dr. Sovik Dubey sir, Dr. Pandit sir, Dr. Bipin Kanti Roy sir, for presenting such a unique case with fabulous presentation and which will be extremely helpful and informative to all the participant DM and DNB students. Once again, thank you for your gracious presence, and it's being a pleasure being with all of you. Thank you, all your patience, and I wish all you a very good night now, with a promise that next on 26th February 2021, we will meet with most awaiting next session of the Secrets of Safe and Take Care. Thank you. Thank you, sir. Thank you very much.
Thank you very much, and Happy New Year, everyone.
Thank you. Thank you.
Thank you, sir.
Thank you, sir.
Everyone,
Lakshmi,
everyone, thank you. Wonderful.
thank you.
I'll call
Thank
on
you so
phone.
much for this
I'll call you on
opportunity.
phone.
Okay, okay, okay.
I'll call you on phone.
Okay.
Wonderful. Beautiful.
Okay, sir. Okay, ji. Thank you.
Excellent session. Thank you.
Thank you.
Thank you, sir.
Thank you so much.
Dr. Lakshmi.